Bismillahirrahmanirrahim. Assalamualaikum and good afternoon. Thank you, Madam Chairman. I would like to say thank you to the organizing committee for inviting me to deliver this lecture. Epilepsy and Cerebral Palsy, how much genetics? I am a clinician, so much of my talk will be based on clinical ground, but as much as possible, I will try to incorporate as with the question in the topic. Okay, first of all, we talk about epilepsy. Just a brief overview about epilepsy. It comes from the Greek, ancient Greek word to mean to seize or to possess. It is a long-term neurological disorder, and it's characterized by seizures. So patient will have fits. The fit can vary. A lot of feature of seizures, ranging from very subtle that you can't really see up to very prolonged generalized convulsion. Sometimes the seizure can be in the form of just what you call aura, just abnormal, funny feeling by the patient. The unique thing about the epilepsy is that the seizure recur. So somebody can have one seizure in their lifetime, so you don't call it epilepsy. But once they have recurrent seizures, then we can call that epilepsy. Before, I've been trying to classify epilepsy by different ways, but at the moment there have not been any solid classification. One of the way that people classify epilepsy is according to the etiology, because epilepsy has got a lot of causes. So you don't have one single reason why somebody developed epilepsy. You have array of reason, maybe from genetic. That's why we are talking about genetics. It can be from injury, from infection, and so on. From etiological point of view, we can classify epilepsy from the genetic cause or presumed genetic. So you think patient have some underlying genetic reason why patient develop epilepsy. We can classify according to the structural. Meaning because epilepsy originated from the brain. So when there's something wrong with the brain in terms of structure, then patient can develop seizures. And there are many patients that you can't really pinpoint the cause of seizures. So we classify as unknown because we don't know what's causing. Patient just develop seizures without any valid reason. So this is one of the cause of epilepsy. When somebody has lesion like this in the brain, so you do imagine that you see lesion like this, it's very, very high possibility patient can develop recurrent seizures. This is another image of the brain where markedly abnormal structure of the brain. This is what we call hemimegalencephaly, because this part of the brain on the right side significantly larger and abnormal shape compared to the left side. One of the things that I would like to highlight is in epilepsy, we try as much as possible, when you see a child with epilepsy, we try to assign a syndrome to the name of the syndrome for any particular patient with epilepsy. So when we talk about syndrome, that means a group of signs and symptoms that when you add together, so it suggests any particular condition. Similarly in epilepsy, so we put together different background of the patient, age of onset, what kind of seizures, and then the features on the EEG, which is the electrical activity in the brain. And then sometimes you need to observe how the disease developed over the years. It's natural history. And then look at the family, and then how does the epilepsy affect the development of the patient, whether the patient goes on to have normal development, or their development become abnormal. And then they respond to the medication that is given. So we put together all these things and we assign a particular syndrome. So for example, there are so many syndromes, I won't mention here. But as an example, based on the age of onset, in neonatal period we have things like Ohtahara syndrome, for example. And in infancy, you have West syndrome. In childhood, you have benign relapsing epilepsy, adolescent, juvenile myoclonic epilepsy, and at any age you can have progressive myoclonic epilepsy. This is the EEG feature that you see in patients with Ohtahara syndrome. So one of the features in Ohtahara syndrome is what you call burst suppression, where on the electrical activity in the brain, there's a period where you have very florid electrical discharge in the brain, followed by very quiet period, and then again burst suppression alternating throughout the recording. So this is what we call burst suppression. So one of the characteristics of Ohtahara syndrome in baby with epilepsy. So you compare with normal EEG like this, so it's totally different from what you saw on the previous slide. So talking about genetic in epilepsy, when you talk about the role of genetic in epilepsy, you can see whether the any particular test or pattern that can predict the risk of developing epilepsy, and then the genetic test itself may give a certain diagnosis of the syndrome, and sometimes perhaps, and we hope that it can predict the response to the medication. To highlight the importance of the role of genetics in epilepsy, we can see the overall incidence when you compare somebody with epilepsy in the general population, which is about only 1%. But if the father has epilepsy, the risk increase about 2 or 3 times, 1.5 to 3%. A bit higher when mother has epilepsy, 3 to 9%. And in the study on identical twin, they found that if one twin has epilepsy, the risk of the other twin, identical twin, develop epilepsy 50 to 60%. But the actual risk depends on the type of epilepsy. So, for example, if you have generalized epilepsy, the risk is higher in the family as opposed to the focal epilepsy. And but I think it's important for me to remind, although you see all these statistics, when you see a particular epilepsy, very few of them actually has family with epilepsy. So in general term, when somebody comes in with seizures, the likelihood is that none in the family actually having epilepsy. These are the normal scenario. But what we are saying here is that the risk is a bit higher if any of the family members has epilepsy. As I mentioned, particular type of epilepsy, they tend to run in the family. Okay, forgive me about this upside down because I need to fill up the slide by this family tree. So this is, you have 1, 2, 3, 5 generation of 5 generation family tree, where you have many of them across the generation develop epilepsy and seizures. Different pattern will denote different type of epilepsy, but they are from different from the similar group of epilepsy, which is febrile seizures, generalized seizures, or myoclonic seizures. So you can see that among the family there are people who develop different type of seizures, but the risks are getting significantly higher. This is another example of family tree with similar type of seizure, where you have so many in the family. Among this 4 generation family tree develop epilepsy. So this picture just to highlight to you that the risk. I mean, when you see a picture like this, you straight away think that, of course, there will be some genetic element in that. And in fact, the initial study on the epilepsy genetics started when people started to notice this kind of pattern in the patient who developed epilepsy. Okay, one of the abnormalities that can occur in patients with epilepsy is chromosomal defects. So it's the gross chromosomal defect. That's why in investigating patients with epilepsy, it's recommended to do karyotyping in patients with intractable. So patients who really do not respond with to anti-epileptic drugs, or the patient who demonstrate dysmorphic appearance. So it's something that we quite commonly do in this kind of patient, the chromosomal study or karyotyping. The example will be Miller-Dicker syndrome, which is a condition with submicroscopic deletion in the short arm of chromosome 17. So this affects at least one gene. So the characteristic of this condition is listen carefully or smooth brain. So the presence of the mutation will result in abnormal structure of the brain. So that results in development of the epilepsy. Usually the epilepsy will start very early in life, even in neonatal period, and many patients will die in infancy. So this feature is to showing to you the deletion on the chromosome 17. They have quite a typical facial appearance. What I notice is that they have quite similar thick, thin upper lip like this, and then hypertelorism and the quite deep facial appearance. Each and every scan of these children showed abnormal brain, which is very smooth. So normal brain, you can see a lot of gyration. The other abnormality that can occur is the ring chromosome, where you have one of the chromosome become ring. So they both ends will come together and become like a ring. Ring chromosome 20 can result in severe epilepsy without obvious dysmorphism. This is the difficulty about this ring chromosome, because you don't see much dysmorphic appearance. For example, this particular patient of mine, where you from one appearance, from one angle, you can't see any obvious dysmorphic appearance of the face. But because she has such a difficult to treat epilepsy, so we send the chromosome study, which turned out to have ring chromosome 20. Apart from chromosome abnormalities, the rest of the patient with epilepsy who has underlying genetic abnormalities are in the form of single gene disorder. So single gene disorder is a result of single mutated gene. So you can identify one particular gene. Whereas in slightly different scenario is what we call genomic imprinting and uniparental disomy. This can affect inherited pattern. Whereas in the single gene disorder, you can have autosomal recessive, autosomal dominant, X-linked recessive, X-linked dominant kind of inheritance. There are at least 20 syndrome whose main feature is epilepsy. So you have single gene disorder, and then patient have epilepsy alone, exclusively, or associated with other condition. But in the syndrome itself, there are at least 20. So you probably heard some of this condition in the previous lecture. These are all single gene disorder where the patient has epilepsy as well as other features that affect multi-system disease. Tuberculosis, Fragile X, neurofibromatosis, Rett syndrome, leukodystrophy, or mucopolysaccharidosis. Whereas in other patient who has some mutation in the gene, they can have what called pure epilepsy. You don't see any abnormalities or syndromic features in this particular patient, and they don't have any other system affected other than the brain, or in other words, seizures itself. You can have mutation that affect can cause what we call channelopathies, the potassium channel, KCN
Q2 and KCNQ3. You can have the calcium channel or even sodium channel mutation causing different epilepsy syndrome. Quite interesting to highlight here is that when people first put patient on this particular epilepsy syndrome, like for example Dravet syndrome. So first of all, people lump together patient and call them Dravet syndrome because they have got similar features. They have epilepsy started very early in infancy. They have multifocal seizures, right, left, sometimes generalized. They have myoclonic seizures. This patient will go on to have abnormal development, mental retardation, and a lot of myoclonic seizures. So they lump together this patient based on this what we call phenotype. Okay, that was years ago. But later on, when they did the testing, they found that most of these patients have mutation in the sodium channel gene, SCN1A gene. So that's how the diagnosis developed. So this example of tuberous sclerosis where you have abnormal skinny appearance. Sometimes we call it neurocutaneous syndrome because patient develop skin blemishes like this. They have what you call hypopigmented skin lesion all over their body, and at the same time they have lesion in the brain. So patient develop epilepsy. Quite a few of them, say 80% of patients with tuberous sclerosis, they have seizures or epilepsy. And the mutation in the chromosome 9 and chromosome 16, TSC1 and TSC2 gene. And most of them actually spontaneous mutation. This is another example of neurocutaneous syndrome. You call it neurofibromatosis, where patient, as opposed to hypopigmented putih, they develop darkish skin lesion. We call it hyperpigmented skin lesion, pigmented skin lesion. At the same time, they can have some lesion in the brain on scan and mutation on chromosome 17. But the incidence of seizures are much less compared with tuberous sclerosis, but much higher when you compare with the general population. Another condition is what called Rett syndrome. You heard this in the previous lecture. It's X-linked dominant, and the mutation is in the MECP2 gene. And the incidence of epilepsy much higher. 70 to 80% of patients with Rett syndrome will develop epilepsy in quite early in life. Quite similar picture in previous lecture. In Fragile X, what I want to highlight here is the incidence of epilepsy is very high, up to 40% in children with Fragile X syndrome. Another syndrome is called Angelman syndrome, where the gene disorder is more of a genetic imprinting. This arises from the lack of maternally derived chromosome 15, the short on Q, and where they have different type of mutation. Can have deletion, majority of them, and then uniparental disomy, imprinting center mutation, or mutation in UBE3A gene. So this kind of patient many of them develop epilepsy early in life. So this is example of patient with Angelman syndrome, quite similar facial features, very happy kind of faces. But many of them develop epilepsy. You probably know this guy. He doesn't have Angelman syndrome, this Colin Farrell, isn't it? Hollywood actor. But his son has Angelman syndrome. So he's quite active in promoting and fighting for the welfare and interests of patients with Angelman syndrome. So now a lot of labs around the world are developing gene test mutation because of the newer techniques. So they will screen patients with epilepsy. They realize from the syndrome that I mentioned earlier that many other mutations can be detected in the patient with epilepsy. So it's been increasingly recognized, but most of them either on research basis or when you ask for the test, it can cost a bomb. It's very expensive. For example, I took this from the website of a lab in United States who offer this kind of test. When I inquired to get the test done for the 50 gene that affects epilepsy in infant and children,
it will set you back around 5,000 US dollar, which is very almost 15,000 ringgit, very expensive. But quite interesting that they have a lot of new tests available. I mentioned potassium channel here. Is very good test here, KCNQ3, because can detect more than 50% of patients with benign familial neonatal seizure. So when you do a test for any patient with epilepsy, the yield is very low. But when we target certain kind of epilepsy syndrome, like this one, the yield can be quite high. And similarly, in PRRT2 gene, autosomal dominant, in benign familial infantile seizure, you can have up to 83% mutation detected. So these are the other list of tests that can be done. This is not the only lab that offer this test. You can have other laboratory around the world, in Europe and in Japan. Some laboratory in our country also offer some of these tests. I know UPM offer at least CDKL5, ARX, and STXBP1 gene for early onset epilepsy. I'm not too sure about USM. You do offer, I think, SCN1A gene mutation some time ago, but probably no longer being done because of the cost. But all this can be done on one blood sample, which is very good. And at the end of the day, the yield will be around 20 to 30% of the selected patient. So that is in non-syndromic. Then you have gene test in syndromic infant. You have features of syndrome like Rett, Angelman, Mowat-Wilson, and array of other syndrome. And then childhood onset as opposed to infant onset, they have slightly different gene, some overlapping, but they can have slightly different gene. For example, the gene that affect juvenile myoclonic epilepsy, which is type of epilepsy that don't develop until about 9-10 years of age. So these are the tests that affect progressive myoclonic epilepsy, generalized epilepsy, and certain epilepsy syndrome. It's quite similar list of tests that you see in childhood epilepsy compared with the infantile onset epilepsy. Okay, for the last few minutes, I want to highlight about the cerebral palsy. Before I prepared the talk, I thought there's nothing much can relate between the CP and the genetics, but as I went through preparing the lecture, I realized that actually that there are more than what I knew before. So I think it is a good thing for me as a clinician. Before that, let us define epilepsy, just to remind some of you who's not familiar. So when you say cerebral palsy, is a disorder that affect the movement and posture. So patient have abnormal movement and funny posture. This kind of movement and posture can affect their function day-to-day life, and this is due to the lesion in the brain, which is non-progressive. They occur one-off, then they don't change over time, and it occurs in developing fetal or infant brain. Just to highlight here that even though the lesion is static, but the manifestation can change over the years. But the important thing is when you scan the brain serially, you don't see any difference over the years. This is how a patient with CP would look. Typically, in patients with diplegic CP, they have very tight muscle in the legs, causing severe tiptoeing like this. This is another patient. Although he could put the feet flat on the ground, the posture is still abnormal if you compare with normal children. And this is another patient with different type of epilepsy, called it spastic dystonic CPA, where they have abnormal posture of the upper limbs. This is what called dystonic posture, where you have contraction of different muscle group opposing antagonist and agonist muscles. And the type of epilepsy is what you call left hemiplegic CP or right hemiplegic CP. So one side of the body affected, whereas the other side can be quite normal.
The worst time of epilepsy is what we call quadriplegic CP, where patient normally bedridden and they can't move from one place to another. They need a lot of help to be taken care of. So as similar to epilepsy, cerebral palsy have different etiology. Many factors can result in CP. What I'm listing here is the traditional cause, what from studies and observations. So these are the causes that we attributed to the cause of CP. Things like the antenatal factors, where patients have the premature deliveries, or patient have a history of abnormal pregnancies. We often associate cerebral palsy with birth asphyxia, where patients have difficulty during labor, during birth. They born flat, they become encephalopathy after birth, they develop seizures, or they have bleeding in the brain during the first few weeks of life, or they have meningitis. Some patient characteristics is where patient have severe jaundice, yellow discoloration of the skin. The level of the bilirubin becomes so high that it enters the brain and can cause damage to the brain. So all these things actually, what condition that may cause damage to the brain at that particular time. So as a result, patient develop CP when they grow up. Even after patient was born, patient may develop insult to the brain, infection or even trauma, either what you call non-accidental or accidental injury. As long as trauma and causing brain injury, there is very high risk of developing CP. One thing that people start to think, rethink about the genetic of, the etiology of epilepsy is that the advance of the obstetric care, you have improved skill of antenatal care, a lot of different tests that you can do for mothers, as well as the highly skilled care for the newborn babies. So despite all this advance, not only in our country but also in most developed countries like United States or Japan or European countries, they can't bring down the incidence of epilepsy, of CP, among the population. Meaning if they compare the population with CP at the age of 2 years now with patient with CP at the age of 10 years, the prevalence remain the same. So they can't bring down the incidence of epilepsy. So that brings the more studies and more thinking about whether there's some genetic element underlying the development of the CP. Even when you talk about patients who have what you call difficulty at birth, they have birth asphyxia, they born flat, they develop neonatal encephalopathy, there might be some underlying genetic predisposition. So why you have this baby who are born normally and another baby have difficulty in labor? So people start think that it could be some underlying genetic condition that can predispose to difficulty during birth process. These are a few points that we can think about when we try to tie between CP and genetics. Okay, some patients with cerebral palsy, they are born with small head, or when you scan the brain, the structure looks abnormal. So, I mean, this long been attributed to some genetic predisposition. So these are the patients who don't have any problem with labor, but they have things happen during pregnancy itself. There are patients who has been diagnosed as epilepsy when they are born or when they are 1, 2, 3 years of age. But as they grow up and then being evaluated by different doctors and subjected to different tests, in some of the patients
has been detected to have genetic mutation. So the practice now is that when you have somebody with genetic mutation who looks like CP, then we start to think, oh, this is not CP. This is genetic abnormalities. So patient doesn't have CP. So the trend, I mean, even at the current moment, this is what we tend to do. We change the diagnosis. Although patient look like CP, but because they have underlying genetic problems, then because of that, patient develop so-called abnormal posture and movement. So we erase the diagnosis of CP from the patient notes. That can happen. That still happen. There are patients who looks very much like CP. They have difficulty. They can't walk. They are bedridden. They are very stiff. But actually, they have some other condition, which is not epilepsy, which is not CP, because they have. Sometimes we call it neurotransmitter disease, or some the element in the brain that transmit the neuronal signal lacking in the structure, in the biochemical ingredient of the neuronal cells, causing abnormal posture. Sometimes we call it dopa responsive dystonia. Recently, this condition detected to have some mutation like GCH1, SPR, or TH gene. So all this genetic mutation results in what we call dopa responsive dystonia. The interesting about this condition is that patient look like CP and bedridden, but because of this genetic condition, when you give them certain medication, especially the levodopa or medication that you give for Parkinson's disease, patient can just stand up and walk. They are fully cured by their condition. Even patient who age more than 10 or 20 years, they simply improve the condition with medication. So this is not CP. So the brain scan is normal, everything is normal, just that they have neurotransmitter disorder. There are patients who have feature like CP, like the picture I showed just now. We call hereditary spastic paraplegia, but the brain scan is normal, the spine scan is normal, and this patient can have mutation in certain gene like ATL1 gene. There is no medication for this. Patient may go on to develop a similar condition like CP, but the special thing about this condition is that it can get worse over time. So like CP, the condition is static, but this is progressive condition. So when you diagnose this, then we have to tell the patient that the lower limb can get worse over time, can affect upper limb, and patient may have offspring or children with similar disorder in the future. So those that we call pseudo CP, where you don't have any lesion in the brain, there are other things that can present like CP, but they are not CP, so there are other conditions. Rett, Angelman, Leschnyhan, they can present just like cerebral palsy, some of them. And this list, actually, the gene mutation that occur in patient with CP that you don't change the diagnosis. So patient have CP, you do the test, and patient remain to be diagnosed as CP. So these are the candidate gene that underlie the development of the CP. So they being detected by different studies among the patient who have CP within the family. So more than 2 patients within the family have CP. So they did the test, and these are the 6 genes that have been detected so far. There are many more being underway. Then we predict that there are more genes detected, and this can be what you call detect earlier in the patient, so that we can predict the risk of developing CP, and maybe perhaps they can open up the window for therapeutic intervention. So as conclusion, so the question is how much genetics? So the answer will be, as mentioned in my lecture, genetic disorder can underlie multi-systemic abnormalities that manifest as epilepsy or exclusively epilepsy without any accompanying learning or behavior problems. In fact, genetic etiology underlies
up to 40% of individual with epilepsy. And in CP, growing body of evidence suggests that CP probably caused by multiple genetic factors. And then the recent advance in the technique of sequencing actually possible for us to diagnose and detect the gene in a more cost-effective manner. So we expect more novel CP genes will be detected in the future, and as our knowledge of the underlying pathophysiological mechanism CP increase, so will be the possibility of developing therapeutic intervention. So this is what we hope happen in the future. So this will hopefully finally reduce the incidence of CP in the population. Thank you.
Thank you, Dr. Noor Azni, for the excellent talk. Can we have some question and answers? Yes.
Hello, doctor. I want to ask just now about the ring chromosome one, right? You said the presentation is epilepsy that's difficult to treat. So after you found out that the patient already has the ring chromosome, will it differ in your management?
At the moment, even if you discover the chromosome abnormalities, that will not change the management for the time being. I'm not sure, but actually it's quite rare to have this condition. So far, my experience only 2 patients that I encounter. It remains intractable, but that's something that you can counsel and explain to the patient. And hopefully, with further advance of genetic tests, we can direct certain specific medication that respond better to this condition.
And Doctor, just now about the definition of CP, right? You said that the neurotransmitter and the genetics, they are not really included. If you found out to have genetic disorders, then you not consider it as CP.
If you talk about neurotransmitter, although the phenotypically it looks like CP, but if you diagnose that condition, that's very good news, because patient can be treated. As opposed to CP, there's no treatment. You can offer symptomatic treatment. Patient improve in terms of the posture, but patient not cured. But in neurotransmitter, patient can be cured with specific medication. That's the unique thing about neurotransmitter. So when you can cure the patient, that's not CP anymore. CP is something that is permanent, static. It's not changed over time.
So it's like a diagnosis of exclusion, is it? There's no other causes besides.
It's something that, from clinician point of view, is when you see a patient with CP, you try to find out what's causing it. Okay. More often than not, you know that patient have something in the past, whether during pregnancy or at birth or after birth, something happened to the patient. So that may explain. Then when you do the scan, you see some abnormal findings on the scans. But some patients, you can't find anything. You don't find any incident in the past. You scan, the brain looks normal. Patient, in fact, can look very intelligent. Although they're very spastic, they are intelligent. So this kind of patient, you may want to test for the neurotransmitter. It can be done. You check the CSF, you send to the specific lab, and you can give you the result of any defect neurotransmitter. Then you can offer the genetic test according to which neurotransmitter defective in the result.
Okay, thank you. Any more questions? Some more questions?
Okay, allow 3.
Other people first. Okay, any other questions? So what is the percentage of DOPA responsive patients?
I can't tell you the percentage. It's still very, very rare. But there's a feeling that they are still being underdiagnosed because many patients don't come to us. They remain in the community, so they're being labeled as CP, so they're being assigned to CP person for the rest of their life.
so they don't come to us, we don't detect them. But it's still very rare, but it's quite underdiagnosed. Probably less than 5% of the total patient with CP.
Okay. My next question is to Dr. Ravi. Sorry, I want to ask. Just now you said that there's 30% of people in Malaysia is suffering from learning disability. Is it? Oh, okay. All school-going children. Actually, when we say that the patient has learning disability, how we know that the patient is not just being slow, just a normal slow, but not.
That is different.
Huh?
Slow learners are different. They make a cope up later.
Make it.
They can cope up later.
You can cope up.
It's not like that, no. They be compared with the
Sorry. Sorry.
Can control their diets to avoid learning disability. So does it mean they have to continue controlling their diet into adulthood, or will it? It can be treated. Oh.
We detect that the child has phenylketonuria, immediately start the treatment so that the child may not be developing like that.
So when they enter adulthood, they don't need to continue that.
Continue, yes.
So, doctor, just now you talk about learning disability, right? If they were diagnosed with learning disability at first, then after that, how about their motor skills?
That depends on several factors are involved. No? IQ is also very important, especially those cases with the syndromic.
Mm-hmm.
IQ will be comparatively less, but whereas those non-syndromic LD, most of them will be having normal IQ also.
Oh, so the learning disability is not equivalent to IQ low, lah.
No.
Oh, okay.
Because
Okay.
some of the celebrities, they have learning problem. Nobody will know that.
Mm-hmm.
They have come up
Okay.
maybe some reading problem, some minor things like that. If they have the learning disability,
Oh,
I
okay.
think it will be normal.
Oh, okay. Okay. Wait, got another question. Anybody else has other question can ask first. Oh. Okay. Just now I really kind of got lost with all the microsatellite stuff. You talk about the microsatellite instability and the loss of heterogeneity, right? Loss of heterogeneity can be found in both acquired and also inherited gene mutation. How about instability? Where does instability comes into the picture of acquired and?
It is similar. Actually, both can happen hereditary as well as through sporadic. Both can like that.
So, doctor, is there any way that we can differentiate between an acquired mutation and also a inherited mutation?
If you do a genetic test for that particular marker, you can find out the change in the repeat of the allele. But clinically, it's very difficult to find out whether it's acquired or sporadic. But doing a molecular test, then you may know that there's change in the repeat of the particular sequence. But clinically, it's very difficult.
Okay, thank you. Yes.
So, okay, I think if there's no more question, that the seminar.